In this capture, we're going to take a look at respiratory assessment, diagnostic testing, and treatment modalities. Just to kind of review a little bit about respiratory anatomy, we have the upper respiratory tract and the lower respiratory tract. So when you think about the nose and the sinuses and the nasal passages, air flows through there, it's humidified, it's warmed before it gets down into the lower respiratory tract. We also have the pharynx with the tonsils and the adenoids. Those are going to be important, particularly when we talk about upper respiratory infections, because those areas can get inflamed and swollen, which can impact airflow. Our larynx, which includes the epiglottis, the glottis, the vocal cords, and the cartilage there, that's responsible for swallowing. It's responsible for speech, sound, that vibration. So that can be very important. Obviously, your trachea is what's going to connect the upper airway to the lower airway, and that's where air flows through. With regard to the lungs, we have two lungs. There's 5 lobes: left upper lobe, left lower lobe, right upper, middle, and lower lobes. Just kind of remember those abbreviations, because when you're doing narrative assessment documentation, you want to be using appropriate abbreviations. We also refer to the top of the lungs or the apex of the lungs. You can call apices if it's plural, right apex, obviously if it's singular. Also, the bottom of the lungs, we often call that the bases. Okay, the right base, left base, bilateral base. We also have the pleura and the mediastinum, and that kind of makes up the anatomy piece. Internally, we have the trachea that comes down, branches off into the right and left mainstem bronchi, which then further branches off into bronchioles, all the way down to the alveoli, which are little sacs of air. Essentially, they're kind of like, they look like little grapes. And down there at the alveoli, that's where there is circulation, there's capillaries, and you have the alveolar capillary membrane, which is where gas exchange takes place. Oxygen that diffuses into the blood, CO2 diffuses back into the alveoli, and then that CO2 is exhaled. Some landmarks you just want to be familiar with if you kind of go back to fundamentals with respiratory assessment and cardiac assessment as well, just making sure you're placing your stethoscope at the correct anatomical locations. So obviously being able to know where the sternum is, know where your mid-clavicular lines are, both on the right and on the left. That right middle lobe, the only place you can really appreciate it from an auscultation standpoint is going to be on the side, on your right lateral side, typically about the nipple line. So you always want to make sure you're assessing there to check out what's happening in that right middle lobe. Posteriorly, when you're listening, again, remembering the scapula, and if you're listening over an area of large bone, that's going to muffle the sound. You're not going to hear it as well. So it's important at the top that you stay really close to the spine and not be listening over top of where the scapula is. Looking at physiology, when we talk about ventilation, that is the movement of air in and out of the airways. That is what's continuously bringing us oxygen and ridding us of CO2. Inspiration happens where the diaphragm actually contracts, so this is an active process. So the chamber floor actually moves down, and we have the contraction of the external intercostal muscles, and that actually changes the pressure inside the thorax, which causes that airflow to move from a greater pressure outside of our body down into the lungs. Okay, so the air enters the airways, it inflates the lungs. Expiration is where the diaphragm relaxes. So this is a very passive process. It's also a process that becomes damaged with COPD, and we'll talk about that in a future capture. But this is where everything relaxes. The pressure is increased inside the thorax. So the pressure inside is greater than outside, and that allows for the air movement to move from the lungs out into the space outside of our body. So it's deflation, and that's where you have the elastic recoil of the lungs. If you think about the respiration cycle, and you remember this from foundations, when we're counting respirations, it's one complete cycle. An inspiration and an expiration together counts as one. So when you're looking at that cycle, inspiration takes about 1/3 of the time, and expiration takes about 2/3. Okay. From a physiology standpoint in relation to gas exchange, and I kind of touched on this a little bit before, but the O2 crosses the alveolar capillary membrane into the arterial blood, and it does this by diffusion. So there's a higher concentration of oxygen in the alveoli than there is in the blood. So it moves from higher to lower concentration. And once that oxygen is then in the blood, it's the process of perfusion or circulation that carries that oxygenated blood to all the body tissues. So when you think about gas exchange, for it to be adequate, it's really going to depend on the balance between what we call ventilation and perfusion, and ventilation and diffusion. So ventilation, how much oxygen I'm taking in, and then of course the diffusion, perfusion part, how much of that oxygen is getting across the alveolar membrane, the alveolar capillary membrane, into the circulation to be perfused throughout the body. So again, with gas exchange, your oxygen is transported to the cells of the body. It combines with hemoglobin to do that. So a factor in this that we haven't talked about yet, it would be if the patient is anemic. So if they have low red blood cells, low hemoglobin, low hematocrit, they have decreased capacity to carry and deliver oxygen to the tissues. That's often why you see pale, skin, cooler temperatures of the skin. So just as oxygen crosses over that alveolar capillary membrane for us to get it from outside the body into the bloodstream to circulate, the opposite process happens with CO2, okay? The CO2 is that byproduct. So when it gets back up to the lungs, that CO2 has to diffuse over the alveolar capillary membrane back to the alveoli and then get exhaled. Okay, so it's a process it's happening all at once, and you can see that from the picture that's on the screen. How air is coming into the lungs, how it comes into the alveoli, and how it diffuses the oxygen from the alveoli into the circulation. I'm going higher to lower. And then the CO2 from the circulation back into the alveoli. Again, I'm going from higher to lower so it can be exhaled. Something to mention would be the cough reflex. This is a very important protective reflex of the airways and lungs, because if you get things down there that are not supposed to be there, it's going to interfere both with ventilation, getting the air into the lungs, and then of course diffusion, getting that oxygen across that alveolar capillary membrane. So the cough reflex, as well as the little cilia that line your respiratory tract, they enhance secretion and particle clearance. And that's what protects us from aspiration. So when you have postnasal drip, when you have allergies and it kind of gets down in your throat, your cilia are working to try to move that back up your throat. So then you get that gag cough reflex and you cough those secretions out. Okay, so cough receptors are in the trachea as well as in the lower airways. So kind of thinking about some health promotion strategies in relation to respiratory health. First of all, infection control. And boy, is this at the forefront right now with the COVID-19. Hand hygiene, hand hygiene, hand hygiene. Wash your hands. Teach your patients to wash their hands. So, so important. The other thing that's good to think about is to avoid touching your face, keeping your hands away from your face, because your hands are the things that are going to be the most dirty on your body because you're constantly touching things. So if somebody coughs, into their hand and they touch your desk and you happen to touch your desk and bring your hand up to your face, you're transmitting those germs. So trying to avoid touching your face as much as possible, and frequent hand hygiene is critical. For some of the disease processes we're going to talk about, limiting exposure to airborne allergens is important. We know there are certain triggers with asthma, with bronchitis, COPD, that kind of sets people into flare-ups. So if we know what those triggers are for a particular patient, and general triggers as well, trying to limit exposure to those. Immunizations are a cornerstone of health promotion. The flu vaccine is recommended annually. The pneumococcal vaccine, those are generally one-time things, but there are actually two different pneumococcal vaccines, the 13 and the 23. And it is recommended that patients over 65 receive both, as well as patients under 65, 18 to 64, who have medical conditions such as asthma, such as COPD, hypertension, diabetes, things that would put them at higher risk. And certainly smoking cessation. Smoking is a huge risk factor for respiratory disease. So obviously stopping smoking, or at least cutting down on smoking as a step towards complete cessation, is definitely recommended. So going back to some basic assessment, with health history, you always really want to hone in on that presenting problem. Okay, so what's going on right now? What are the associated symptoms? What was the timing of the onset? How did their symptoms progress? You also want to consider their past medical history, past surgical history, any type of injuries that they might have had. And it could be from a long time ago. Maybe someone was in a motor vehicle accident, but they experienced some, chest trauma. That can certainly impact respiratory diseases and disorders that they have later on in life. Hospitalizations, any allergies, again, because respiratory symptoms a lot of times can be associated with allergies. And of course, the current meds, not only prescription, but over the counter, vitamins, herbals, anything like that. You want to assess their risk factors and also genetic factors. We're going to talk very briefly in a future capture about cystic fibrosis. So that has a genetic component. COPD, mostly related to smoking, but there is a subtype of COPD that is related to a genetic disorder. They actually have a deficiency in a certain enzyme. And of course, you would want to know about the patient's immunization history. For the physical exam, you want to look at that focused respiratory assessment. So you want to note the respiratory rate, the rhythm, the pattern, the depth. Are they shallow? Are they deep respirations? Is it a regular or an irregular pattern? You also want to note their effort. Are they breathing very easily, or are they starting to work to breathe? And you want to note that both at rest and with exertion. So are they short of air at rest? Are they dyspneic on exertion? Are they using those accessory muscles? Okay, thinking about the neck muscles, thinking about the intercostal muscles. So really taking a look at how the patient is presenting, that effort. You want to note whether they have a cough. And if they do, is it productive or non-productive? And if it's non-productive, is it a dry or a moist cough? That's pretty important, because if it's moist, it indicates that there's secretions down there that really do need to come out. Also noting, is the cough weak? Is it strong? Is it kind of a continuous persistent cough, or is it intermittent? What kind of brings that cough on? Along with cough, we also look at sputum. Okay, if they're bringing stuff up, and you do want to encourage them, if they're bringing stuff up, they really need to cough it out, spit it out. A lot of patients will cough it up, it'll get to the back of their throat, and then they'll swallow it. And while that does clear their airway, which is a good thing, it kind of hinders our assessment, because there's a lot you can tell from the sputum as well. How much sputum are they having? What's the color? Is it kind of like a yellow-green? Is it a brown? Does it have blood in it? Is it hemoptysis? What is the consistency? Is it a thin sputum that's a little bit easier to cough up, or is it very thick and tenacious? That would be more likely to block that airway. Certainly you want to note the O2 sat, as well as if the patient is requiring any supplemental oxygen. If they are, how much oxygen do they need? And what is the delivery device? Of course, overall oxygenation, you want to assess with skin color, also nail color, certainly nail clubbing. And you'll look at this in your ATI readings, but nail clubbing is actually the change in the shape of a nail. It is an indicator of long-term hypoxia, so you often see this with COPD, long-term COPD. Certainly breath sounds, thinking about your adventitious sounds, your crackles, your rhonchi, your wheezes, as well as your normal sounds. What should you be hearing, and where should you be hearing those? The bronchial, bronchovesicular, and your vesicular sounds. And certainly, level of consciousness and orientation plays a role here, because if your patient is hypoxic, they're not getting enough oxygen, they're going to start showing some changes in their orientation. And even if somebody has a history of dementia or a history of confusion, usually it's an increase from their baseline. So that's something you want to keep an eye out for. So with your breath sounds, I just kind of mentioned these earlier, but bronchial breath sounds, they tend to be high pitched, they're longer, they're louder. They're heard primarily over the trachea. So if you took your own stethoscope and listened over your trachea, that's what bronchial breath sounds should sound like. Bronchovesicular is more of a medium pitch, and it's heard during expiration more so. You hear it over the upper anterior chest, because this is kind of where your bronchi are starting to branch off into the bronchioles. Your vesicular sounds, these are a very low pitched, soft sound. You're hearing it over most of your lungs. This is what you're listening to and hearing what's going on with the alveoli. As I mentioned before, your adventitious sounds are abnormal. So crackles generally indicate the presence of fluid, really in the alveoli, because when your patient's breathing in, that air has to pass through that liquid in the alveoli to get to that alveolar capillary membrane. And when there's crackles, that actually impairs gas exchange. Wheezes, high-pitched sounds, this is typically due to a narrowing of the airway. Rhonchi is more of a lower-pitched snoring or like a low-pitched wheeze type sound, and this usually indicates secretions in the airways, maybe in the bronchi, in the bronchioles, that the air is having to, get through, and that's what's causing that sound. And then there's a friction rub, and this really has to do when there's a lack or reduction of pleural fluid and the lungs are actually rubbing against the inside of the thoracic cavity. So diagnostic testing, there's some things that are respiratory specific, and there are some things that are kind of general. So the CBC with differential, not specific to respiratory, but certainly we're looking to see, is the white count elevated, are the neutrophils elevated? That would indicate a potential infection. Low red blood cells, low H&H, that would indicate anemia, which may not necessarily be related directly to the respiratory piece. However, just keep in mind that it is the hemoglobin that carries the oxygen in the blood. So if your patient is profoundly anemic, that is going to affect the amount of oxygen that is getting to their cells for body functioning. Certainly an arterial blood gas, where we're drawing an arterial blood sample and we're looking at the pH, the PCO2, the bicarb, PO2 and O2 sat. We also look at base excess. So that's something that as a nurse, as a nursing student, you just need to know those values. There will be ABGs in this unit. Other diagnostic testing, certainly chest x-ray, CT, MRI, nuclear lung scans. Those are, again, looking for different disease processes to kind of figure out what's going on causing our respiratory problem. Fluoroscopic studies, including angiography. This, again, is going to look at structure. It's going to look at blood flow in relation to the angiography. Endoscopy, we can actually do a bronchoscopy where they will go down, similar to an EGD, except instead of going down the esophagus, we're actually going down the trachea and into the bronchi. We can do a thoracoscopy where they actually make an incision into the chest cavity and they go in with a scope to kind of see what's going on external to the lungs. And thoracentesis is a procedure that is used to drain excess lung fluid that accumulates that might be contributing to a patient's shortness of breath. With those types of procedures, the endoscopy and the surgical stuff, they can do a biopsy, they can take samples and be looking for different disease processes, including the presence of cancer. So kind of flipping back to ABGs a little bit, and this should be a review from foundations, okay? So, because you did cover ABGs and foundations. But if you're looking at the very basic interpretation, you start by looking at the pH level and determining if it's acidic or if it's alkalytic. If there is a normal pH, you want to see what direction it's leaning towards. Once you've done that, you then want to look at the PCO2. Again, is it high, which would indicate it's acidic, or is it low, which would indicate it's alkalytic? So this is why you need to know your numbers. From there, you want to look at the bicarb level. Again, is it low, which would indicate it's acidic, or is it high, which would indicate it's alkalytic? So once you've done that with the pH, the PCO2, and the HCO3, what you need to know is the pH is going to tell you whether it's acidosis or alkalosis, okay? But it's the PCO2 and the bicarb that are going to determine whether it's metabolic or respiratory. So when you look at those, which one is going in the same direction? Not necessarily up or low, but which one, if it's a metabolic, if it's an acidosis, which one is going in the same acidosis direction, okay? That's what's going to tell you if it's respiratory or metabolic. Then the next step is going to be looking at seeing if there's any compensation taking place. And this is where you see the one that's not going in the same direction, that's going in the opposite direction. How far is it going in the opposite direction? Are we starting to see the body trying to compensate for the problem? So with acid-base disorders and compensation, just some basic things to kind of keep in mind. And I'm focusing mostly on respiratory here because Unit 5 is respiratory cardiac. Respiratory acidosis, what happens is there's too much acid in the body. Okay, it's a respiratory problem, so the kidneys are going to try to compensate to fix the problem. But if you remember from foundations, the kidneys, they do this, but it takes them a while to get going. You're not going to really see the beginnings of compensation typically for at least 24 hours. So what will happen is in a patient who has respiratory acidosis, the kidneys will retain bicarbonate in the urine, okay, or retain it in the body rather than excreting it in the urine to try to balance that out. So in respiratory alkalosis, the opposite's going to happen, okay? I don't have enough acid in the body, so my kidneys are going to try to get rid of bicarb through the urine to try to balance that out, okay? When it's a metabolic problem, then the compensation happens through the lungs. So whatever the issue is, whether it's acidosis or alkalosis, the ventilation rate is going to be essentially the compensation piece. So in metabolic acidosis, the ventilation rate will increase. So the respiratory rate will increase, the depth will increase because the body is trying to blow off excess CO2. Okay. If it's metabolic alkalosis, the respiratory rate will actually decrease, and then that will try to hold on to some of that CO2 because we're not breathing it out. And then, of course, the kidneys, depending on how functioning they are, the kidneys are going to adjust how much bicarbonate they retain. So when you're looking at interpretation, there are now two additional pieces you want to kind of look at. And I'm just going to touch on these. We're not going to hit them a whole lot. You were going to hit this much more in depth in MedSurg 2 and MedSurg 3. But when you're looking at a set of ABGs, there's going to be a calculation or a number that refers to what we call base excess. And it's a calculation that's done based on the pH, the PCO2, and the hematocrit. Okay, so basically, if there is a negative, it's going to indicate that there's a metabolic acidosis. Okay, if it's positive, you're looking at an alkalosis, or you're looking at, compensation of a long-term respiratory acidosis problem. Again, just something I want you to be familiar with on just a superficial level at this point, so that base excess doesn't throw you, just to be familiar with it. Same thing with the anion gap, and this is actually part of what we call the basic metabolic panel blood work that we do. But this looks at the difference between the cations and the anions in the extracellular space. And, if the anion gap is increased, you're going to see that in metabolic acidosis disorders. So sometimes it can be helpful to figuring out what the cause is. Looking at additional diagnostic testing, pulmonary function tests, PFTs, this is going to evaluate the function, the lung, and the function, the volume, and the capacities of the lungs. It is the gold standard for truly diagnosing COPD. And it is also used periodically to monitor their response to therapy. So it's not uncommon for patients to maybe have PFTs every year, every 2 years, in early to moderate COPD, and maybe a little bit more often as they progress. So there's a lot of different things that they look at, and they're displayed for you on the screen: tidal volume, inspiratory reserve volume. Forced expiratory volume is really going to be the big factor that we look at for diagnosis. But essentially, a patient's results are going to be interpreted against normal values. Now, you have to understand that normal is a wide range. So, for somebody with very, very early stage COPD, their PFTs may actually look normal, the results. So that's where PFTs are useful in diagnosing if they're starting to get to what we call moderate COPD, and it's very useful in trending how their disease is progressing. So looking at some different treatment modalities, you should be familiar with incentive spirometer. You know the patients inhale slowly and deeply. We want to maximize lung inflation, alveoli expansion. It's mainly used to prevent or help treat atelectasis. You should be familiar with nebulizers. I'm sure you've seen them out in the clinical setting. These are a handheld apparatus, and it disperses either a moisturizing agent. Sometimes we'll use saline nebulizers just to try to provide some hydration into the secretions and make it easier for them to cough them up. Or many times these are used to disperse medications into the lungs. Nebulized bronchodilators, nebulized anticholinergics, nebulized corticosteroids, sometimes nebulized antibiotics. So a lot of times respiratory therapy is the one who's administering the nebulizers. However, as a nurse, you need to know how to do it, because if you're working in a facility without respiratory therapy, or in an emergency situation and that patient needs that breathing treatment now, you need to know how to be able to administer it. You also need to know this information because you may be the one teaching the patient or the patient's family, because asthma, respiratory problems are very common in children as well. So there's that education piece that the RN's involved with. So with nebulizers, you want to instruct the patient to take slow, deep breaths through the mouth and hold it a couple seconds. And every couple breaths, you want to encourage the patient to cough. After the nebulizer is complete, you want to encourage some deep breathing and coughing, because the idea, particularly if we're using bronchodilator nebulizers, is to help open up the airways. Well, if I have a bigger space, it's easier for me to hack up that sputum. So doing coughing, deep breathing after nebulizers is when it can be most effective. Postural drainage basically it involves positioning of the patient in various different positions, but it allows the force of gravity to help assist in removing secretions in the airway. This can be helpful with coughing. If they're in certain positions, that might be able to help stimulate the cough. A lot of times postural drainage is done in conjunction with percussion and vibration. So chest percussion is where we're cupping the hands and we're lightly striking the chest wall. It sounds very rhythmic, but basically you're applying some external force. Now again, you're not beating your patient, but you're doing it nice and light to try to create some percussion, create some vibration to loosen up the secretions in the airway. If they're looser, then when that patient does that deep breathing and the coughing, the idea is for them to be able to expectorate that sputum. Vibration works very similar, except it generally uses like a vibration vest that creates that vibration, that tremors. Again, it's all about loosening the secretions from the respiratory tract wall so they're easier to cough up. You see the vibration vests used a lot in patients with cystic fibrosis. Oxygen therapy is a treatment modality. When you think about the air you breathe in just from, the oxygen you breathe in just from the air around you, it's about 21% oxygen. So if we need more than that, we can use supplemental oxygen therapy. So the idea when we do that is to provide more oxygen in the blood, because if there's adequate oxygen in the blood that's circulating, then the lungs don't have to work as hard. It reduces stress on the heart, because for the lungs to work, that does take energy, those respiratory cells, the muscle cells for contraction. It does take energy. You need the heart beating, the myocardium contracting in order to provide that energy, to provide the oxygen and the glucose for the cells to make ATP. So hypoxemia is a decrease in the arterial blood oxygen. Hypoxia is a decrease in the O2 to the tissues and the cells. And it's important to understand that severe hypoxia is life-threatening. Okay, it will eventually kill your patient. So with oxygen therapy, delivery, there's many different ways you can do this. So it can be piped in, similar to what you see in the hospital settings where you have the flow meter on the wall. It can be an oxygen cylinder, a portable cylinder, which is what we use if we're transporting the patient. Home oxygen, they generally use what they call oxygen concentrators. That it's a machine that actually helps pull in oxygen from the air, helps concentrate it, and then is able to deliver it to the patient. You can have low flow oxygen, high flow oxygen, again, portable, stationary. Humidity, depending on how much supplemental oxygen your patient requires, we may need to humidify that. Also, if we're bypassing the upper airway, such as a patient who has a trach, we absolutely need to humidify that oxygen that's going in there. There's different devices, all the way from nasal cannula, simple mask, a partial rebreather, non-rebreather, a Venturi mask. Venturi mask is actually the best if your patient requires higher amounts of oxygen, because it's very specific. It can be adjusted to provide the appropriate amount of oxygen flowing in there, percentage-wise. Most patients, you're going to look and see it's usually 2 to 4 liters per minute via nasal cannula, or if they're on a Venturi mask, it's usually up to 40%. As we talk about COPD in a future capture, some COPD patients are classified or then subclassified as CO2 retainers. If they're a CO2 retainer, we generally do not want to take them above 2 liters of oxygen per minute, because their drive to breathe is based on low oxygen levels versus a normal person who our drive to breathe is based on high CO2 levels. Okay, so if you are dropping their O2, these patients will literally stop breathing on you. So that's a key point you want to understand. The other thing we get concerned about, particularly with your COPD CO2 retainers, is oxygen toxicity. So, and this can happen with other patients too, but the highest risk is going to be for patients that are receiving O2 concentrations that are above 50% for an extended period of time. And we usually say that's greater than 48 hours. So this is a concern that we get, particularly when patients require mechanical ventilation or they're requiring BiPAP. So you want to always use the lowest effective concentration. A lot of times we'll use PEEP, which is positive end expiratory pressure, or we'll use CPAP, continuous positive airway pressure. These things kind of help keep the alveoli from collapsing completely during exhalation, so it makes it a little bit easier to ventilate and oxygenate with the next breath. Signs of oxygen toxicity you want to watch for: substernal discomfort, development of a non-productive cough, nasal stuffiness, dyspnea, restlessness, and essentially progressive respiratory difficulty. As they do chest x-rays on these patients, it will show atelectasis, it will show infiltrates, but you can't wait for the chest x-ray. You need to be watching for signs of oxygen toxicity, particularly in your high-risk patients. There's other treatment modalities that were in your required reading: endotracheal intubation, trach and mechanical ventilation. Those are things you're going to address much more in depth as you move to Med-Surg 2, Med-Surg 3. Even suctioning, you'll learn the procedure for suctioning next semester. For now, I want you to understand that suctioning is important for helping to keep the airway clear because it's going to remove secretions, and understand that it is a sterile procedure because we don't want to introduce microbes for potential infection into the respiratory tract. Non-invasive positive pressure ventilation. So these are things that we would do before the patient gets intubated and ventilated. I mentioned them a little bit before, your PEEP, your BiPAP, and your CPAP. Other treatment modalities, chest tube. That is often used if a patient has a collapsed lung, if they have a pneumothorax or they have a hemothorax. That is when we would typically use a chest tube. And finally, I just want to kind of wrap up this particular capture with just reinforcing some general interventions. When you look at nursing process and you look at nursing diagnoses, and there's different nursing diagnoses out there. The big three, as I like to call them for respiratory, are ineffective airway clearance, ineffective breathing pattern, and impaired gas exchange. Okay, so if it's airway clearance, they have a problem keeping their airway clear. So we can typically look at this for somebody who has a non-productive cough or copious amounts of secretions that they're not able to clear on their own. Ineffective breathing pattern has to do with the actual ventilation piece. So if you think about somebody that's not effectively bringing oxygen into their lungs or effectively expelling CO2 from their lungs. So this can be anybody from a drug overdose, just receiving too much narcotics post-operatively, to COPD because they're not exhaling all of that CO2, they're retaining some of that. Then there's the issue with impaired gas exchange. So this problem is actually down at the alveolar capillary membrane. So you'll see this in a patient with pneumonia. You see this in a patient with atelectasis. You'll see this in a patient with pulmonary embolism. Here's the thing. Regardless of whether it's airway clearance, a breathing ventilation problem, or a gas exchange problem, they're still having problems with oxygenation, okay? And ultimately, your body cells need oxygen to survive. So when we talk about general interventions, these are things that are going to apply pretty much to all respiratory patients, regardless of what the underlying pathophysiology is. Hydration is important, both IV and PO. And the idea for this of hydration is to support circulating volume, but it's also to help with the secretion management. If a patient is well hydrated, those secretions tend to be a little bit thinner. It's going to be easier to cough up thinner secretions as opposed to something that's very thick, sticky, and tenacious. Nutrition is going to be very important. Particularly, we want to increase protein, we want to increase calories, and we want to provide easy to chew foods. This is very simple. If your patient is working harder to breathe, their body is using more energy. For them to use more energy, they need to make more ATP. For them to make more ATP, they need more of the base blocks. They need more of the protein, they need more of the glucose, they need more oxygen. So that's the nutrition piece. I want easy to chew foods because I don't want to expend a lot of energy in taking in those calories. Okay? If they're expending more calories working to breathe while they're trying to eat something that's really difficult to chew, then essentially it's a net loss. They expended what they have already taken in, and it's resulted in nothing. Frequent turning and early mobilization. These things are going to be critical for several reasons. One, the early mobilization stimulates them to take deeper breaths. I'm inflating that alveoli. But also turning and moving helps move secretions in the airway. So you want to mobilize those secretions so they're easier to cough up. Energy conservation is very important because these patients will get short of breath and fatigued very easily. The other diagnosis that I don't have up there is activity intolerance. Very, very common with respiratory problems. So as a nurse, I want to help the patient conserve their energy. I don't want them to be on complete bed rest because that'll put them at risk for, clots and other issues. But I do want to make sure I'm having them conserve their energy. So this is spacing out activities throughout the day. It's providing assistance with ADLs as needed. In fundamentals, we talk to you about promoting independence, and we want the patient to do as much as possible for themselves. And generally, that's true. In this situation, though, I need to space out those ADL activities, or I may need to do those ADL activities completely at first until they start progressing with their recovery. Chest physiotherapy, we talked a little bit about that. Again, loosening up those secretions, incentive spirometer and the flutter valve. Again, opening up the airways, loosening the secretions, making it easier to cough that stuff up. Coughing, deep breathing. Secretion management, we've kind of hit a lot of pieces with that, but they may require suctioning. Okay? And again, supplemental oxygen with humidification.